Hey guys, this is a video series on smoking cessation. I'm your host, Ken Wong. So let's talk about the epidemiology of smoking. Well, do you guys know the population of the United States in 2016? So in 2016, we actually have 323 million people. That's quite a lot, eh? So what's the percentage of people who reported to have current or past use of tobacco product during that period of time? It's interestingly 24%. That's a lot of people. It's about 63 million. This shows that we need to do a better job at counseling patients, understanding what smoking cessation entails. And interestingly, in this 63 million, the highest age group who smoke is 18 to 25. Now, let's look at the types of tobacco use. Now, we've got cigarette, chewing, and vape. What do you think, how many milligrams of nicotine do you think one cigarette would actually give you? It's about 1 milligram. What about chewing? Well, I guess it depends on how much you chew, but it's about 2 to 3 milligrams of nicotine. What about vaping? Now, vaping is an interesting one because you can actually get different nicotine content of the cartridge, so I'm not sure. If you guys know the answer, just let me know. I'll put it in the link. I'll probably put it in the video as well. How many cigarettes are there in a pack? There's 20 cigarettes, right? And how much do you think a pack of cigarettes would actually cost? Well, it ranges from like $5 to $7 here in Ohio. It really depends on the state. It is actually important to know how many cigarettes there are in a pack, because then you know exactly what a pack means when we're talking about 1 pack per year, how much nicotine milligrams per patch to use. All right, let's look at the how the nicotine is actually metabolized. So it's primarily metabolized in the liver into cotinine. Now, do you guys know the half-life of nicotine? It's probably around 2 hours. What about cotinine? It's long. That's actually how we screen, or healthcare providers screen, for nicotine use. So let's look at why is smoking so, satisfying. It's all because of the nicotine component, correct? Now, what does nicotine do? Now, nicotine is actually a psychoactive component of a tobacco. And what does it act on? It acts on this methylcholine. Methylcholine receptors, also known as the nicotine receptors. And what does it do to our body? It actually causes increased alertness, improved attention, and decreased appetite. Now, these are a lot of things that a lot of people want. Well, I want these. I want to be more alert, more attentive, and decrease appetite so we don't gain weight. That is why us as humans want this chemical. And it can be absorbed through lungs, through oral or nasal mucosa when it's chewed or sniffed. Interestingly, when ingested, it's actually very poorly absorbed. So now that you know what it actually nicotine does to our body, you can tell when we have nicotine withdrawal. So usually, well, not always, the first few days of abstinence from nicotine, you get increased craving, irritability, very anxious, difficulty concentrating. Concentration, very restless, slowing of the heart rate, and what? Increased appetite. It's kind of the opposite of everything that nicotine does to our body. Now, typically all the symptoms may last from day 1 of abstinence up to day 4 to probably about 1 month. However, the craving and increased appetite can last up to a long time. It could be 6 months or longer. It's kind of unpleasant, right? Stop smoking, do the right thing, and then you start having increased appetite, increased weight, and craving, and irritability, and all those things. So this is when nicotine replacement really comes into play. It acts on the same receptor, so that a person doesn't have too much of this craving and increased appetite. Now let us look at the harm of smoking cessation before we actually go to malignancy. Let's look at just overall mortality of smoking use. There's an analysis of data from a nurse health study that further look into the health impact of smoking. They compared people who never smoke and current smokers, found that smokers actually has increased risk of overall mortality. For about adjusted hazard ratio is 2.8. And for former smoker, adjusted hazard ratio was 1.2. Interestingly, for people who smoke, when it's compared to never smoker, when they smoke 1 to 14 cigarettes a day, the hazard ratio is about 1.2. I'm sorry, it's actually 2. And then when it's 35 cigarettes a day, the hazard ratio is 4.4. And the overall mortality for former smoker declined significantly within the first 5 years after quitting and decreased to a level of never smokers after 20 years. As you all may know, that smoking can cause a lot of nasty conditions. So in cardiovascular disease, as you guys already know, that it can cause AAA. That's why we screen for them in males above 65 years old. Peripheral vascular disease, cardiovascular disease, and so on and so forth. In the lungs, pardon my drawing, you also have COPD, increased risk of infection, with pneumonia, TB, influenza. So a lot of bad things. And of course, it causes malignancy, as we all know. Now, the proven cause of malignancy in smoking, of course, you guys know, is lung cancer. That's the number one. It's actually a top 3 lung cancer in the world. The other potential cancer is also colorectal, head and neck. Oops, sorry. Especially esophagus as well. And this can be squamous, and it can also be adenocarcinoma as well. And the others are liver, kidney, mesothelioma, leukemia, nasal cavity and paranasal sinus cancer, pancreatic, stomach, penis, uterine cervix as well. And I'm just going to say ... and more. So how can we prevent all these? Now it comes to the 5 A's in behavioral modification counseling. All right, so the first A is what? Ask. There you go. The second A is advise. We're going to go through this one by one. And the third is assess. Fourth, assist. Fifth, arrange. Now, they all play a very important role. Now, the first one is ask. Give them permission to ask them, is it okay to talk about this? Identify this. Is a problem every single visit. A brief counseling actually would really help. And sometimes we would even take this as expand the vital sign to include tobacco use. So there's actually no difference between a counselor and a physician counseling. The benefit is still the same. Even a brief counseling or a brief advice would be beneficial, statistically beneficial, for the patient to quit smoking. And next is advice. What you do in advice is actually you want to entwine or link the patient's current condition to smoking. Why it is bad. Even it's better if you can have the patient to actually say it out loud, so it's actually their information. They're just letting you know. That actually really empowers the patient to actually quit smoking. And the third is assess. It's basically to determine the willingness to make a quit attempt. You want to see how strongly the patient is willing to smoke from 0 to 10, 10 being the most very willing. The second question that I always ask my patient is, how successful do you think you will be at quitting smoking? And that's, I think, is very strong. It gives the patient an idea of how begin with the end in mind. So that to me, I think is really helpful. As with assist, as you know, there's actually the stages of behavior. Some in denial and some is prepared. So you've got your pre-contemplative state, contemplative state, the preparedness, and own remission. So the ideal thing is you want them to set a quit date. And generally, it's within 2 weeks. You want them to start, when they're prepared, you want them to start not too far away, but within 2 weeks, so that their motivation is still high. And we can talk more about how the methods that we can use with this, because there's actually quite a few methods. Last but not least, arrange is basically to arrange for follow-up. Always follow up on the patient, maybe a week or 2 weeks after you start this conversation, especially when they're in the preparation phase. Ask them, how are you doing? Reassuring them that the withdrawal symptoms, all those things is very normal. It's not just them who experiencing all the symptoms, but also the same thing with all the other patients that we see. If the patient was not willing to quit at the same on that visit, or not willing to talk about it, always arrange by saying, hey, if you're willing to quit smoking, please do not hesitate to call us. Do not hesitate to make an appointment so that we can talk to you more about this. This will give them an option that, hey, quitting smoking, it is a choice, and we're here to help. That there's resources here. Nobody's judging. We're all here to help you to decrease complication risk. All right, now let's talk about the first-line pharmacotherapy of smoking cessation. So your first one is nicotine replacement therapy. So you've got different options. You've got gum, lozenges, patch, nasal spray, inhaler. The most common ones that we typically use is this. Some of them you can even get it over the counter. Now, it depends on which source you read. In UpToDate, they actually recommend using a long-acting and a short-acting. So typically, a long-acting is your patch. So it takes about 0.5 hours to 2 hours for it to peak, for a person to actually have the effect of the nicotine effect. So during that period of time, a person can still undergo withdrawal. So this is when you use gum or lozenges. Actually, nasal spray has the fastest acting, but it also has irritation to the mucosa. So you can use the nicotine gum as a short-acting while waiting for the long-acting, the patch, to work. Now, as you can see over here, depending on how many cigarettes a person uses a day, your milligram doses and also your patch doses will be very different. Typically, for the gum is what we call a chew and park technique. So basically, you chew on the gum until the taste comes out. Then when you park that gum onto the your cheek area, the buccal area, for the nicotine to get absorbed to the system. And when there's no taste anymore, that's when you chew some more and get a taste out and then park again. You can potentially use this up to 24 pieces a day, so one piece an hour. The not so good effect is it may have an unpleasant taste. It can damage dental work, or people with dentures is kind of hard to use. And in that case, then that's when you use lozenges. As for the patch, typically you put it on during the day, take it off the next day, and put a new one on. If a person has problem sleeping, nightmare, and whatnot, you can actually take that off at night. To prevent that. However, in the morning, it does take, again, some time for it to work. So in that case, you might want to use the short-acting along with the long-acting. As for all these, typically you can use it indefinitely. For patch, there's actually a taper dose that you can use. So if, let's say, you're using 21 milligrams for 6 weeks, you can taper it down to 14 milligrams for another 2 weeks, and then down again to 7. So there's actually a taper dosing, but ideally all these can be used indefinitely as well. Don't forget to warn your ulcerative colitis patients once they stop smoking in the hospital. Their UC might get worse. So sometimes maybe nicotine replacement might be able to help that out a little bit. Now next, we're going to talk about Chantix. Varenicline. Well, I guess depending on how you pronounce it. What it really does, it actually reduces the symptoms of nicotine withdrawal, literally by blocking nicotine from binding to the receptor that causes the dependence. And how does it do that? It's an alpha-4 beta-2 nicotinic receptor agonist. Now, the common side effect for Chantix or varenicline is nausea and sleep disorder. It can give you insomnia or abnormal dreams. Now, in the past, varenicline had a pretty bad press in terms of causing excessive neuropsychiatric side effect. However, in December of 2016, FDA actually removed the black box warning about the potential neuropsychiatric side effect that was required back in 2009. So a typical dose of varenicline is actually 0.5 milligram per day for 3 days, and then 0.5 milligram twice a day for 4 days, and then 1 milligram twice a day. You don't really have to memorize this. It's actually, when you type that in ECW, you can actually get that, Chantix starter pack. Ideally, you want to start 1 to 2 weeks before your quit date. Now, this is why we talk about quit date is so important. It's because of this. It can also be started 4 weeks prior to quit date as well. That's fine. Ideally, you want to do this for about 12 weeks. After the starter pack, it will be a maintenance dose of 1 milligram twice a day for 12 weeks. And the patient can smoke, that's fine, but they're not going to get the same kind of high that they used to get. But if it doesn't work by 12 weeks, it's not going to be useful. However, if it's useful to maintain remission, then you can do another 12 weeks of therapy to remain in remission. However, anything after that, technically you can consider this indefinitely, but you may have some problem with insurance. Next, we're going to talk about Wellbutrin. The good thing about Wellbutrin is it has something called blunt post-cessation weight gain. Who doesn't want that? So it would be great for people who doesn't want to gain weight to use Wellbutrin. Also, if a person has depression, even, perfect. You've got 2 reasons to use this medication. Just keep in mind that the dose, this Wellbutrin, it should be SR, sustained release, and the dose is slightly higher than normally you would do for depression initially. And the side effect for this is, again, insomnia, can't spell, agitation, dry mouth, headache, Assume you guys can read my chicken scratch. But I'm going to change this to something in red in color, or pink maybe. Do not use in people with seizure. You're going to get this in your test. You're going to get this on patient as well. Just to make sure a person is on an anti-seizure medication, person that history of seizure, don't use this. If a person has great effect within 12 weeks, 3 months, you can actually continue this indefinitely, especially when a person has depression. So, now there are some sources. Let me just zoom out. There are some sources that advocates for, so John Hopkins I'm talking about, using a nicotine replacement plus either varenicline or Wellbutrin might provide a better effect. If you look at UpToDate, they actually recommend either Chantix or nicotine replacement or Wellbutrin if it doesn't work, then you can potentially combine. Now, not combining this two, but more like Chantix plus nicotine replacement or Wellbutrin plus nicotine replacement as a second line combination. Now, if Chantix doesn't work, you can try Wellbutrin. If Wellbutrin doesn't work, you can try Chantix, unless if there's contraindication, of course. Now, that's it for smoking cessation. I hope you learned something. I know there's a lot of information, but it's okay. That's what we have the PBL for. You can ask questions. Some of this, actually, majority of this would probably be in your tests, in your boards, I mean. So feel free, if you have any questions, let me know. I got majority of the source from John Hopkins module 2019. Please do the module. It's great. I still do them all the time. Every time when I do a lecture series on this, I actually go back in and review all the questions. And also, the other source is UpToDate as well. Great resource. Well, let me know if there's any questions. Thank you for listening.